The information presented in this program should not replace the medical advice of your physician. You should not use this information to diagnose or treat any disease without first consulting with your physician or other healthcare provider. CVMD.org, your window to the medical world. Brought to you by Arizona Heart. Produced by VAS Communications.
Way up there, down under. And as you know, the Arizona Heart Institute has always been involved in new technology, showcasing new methods of treatment, and giving what we call the best to our particular patients in different situations and different disease conditions. Recently, I had the opportunity of going down under, rather, to Sydney, to see some other technology which has sort of not taken off right here in the United States, and there are various reasons for that, and one of it could be the regulatory issues involved with the FDA. But this is the new technology that's coming about right now, and it deals with the next generation of endografts. Right now, we are at the cutting edge of doing all kinds of endografting for abdominal as well as thoracic aneurysms. But there are certain anatomical and morphological characteristics that we cannot use the currently available grafts to treat these patients. And these are those patients with short necks, large necks, where the renal arteries come off very close to the aneurysmal dilatation or the aneurysmal section of the aorta. And for these, we've been pushing the limits of our technology that we have right here and putting our available endografts in very short necks, risking the chance of migration, recurrence, endoleak, and even ruptures. So technology has advanced, and worldwide there have been about 1,500 fenestrated or branched endografts done all over the world, and a large majority of them have been done in Australia. This is a classic example of a patient who has a large neck, as you can see. If you go back here, you can see this neck is largely dilated. So the currently available endografts only accommodated a neck of 26 millimeters in diameter to 28 millimeters in diameter. So this is already aneurysmal. It's very close to the kidney arteries. So you can sort of treat this aneurysm with a large device like we use, like an aortouniiliac device, but we may not be doing the right kind of an operation for this diffusely diseased neck. That is the distal anatomy. So what we have here is an example, and this is one of the cases we did in Adelaide with the help of Dr. John Anderson, and a lot of these slides are courtesy of David Hartley and John Anderson, is what is known as a fenestrated or branched endografts, where these grafts have branches or fenestrations that go into the visceral arteries, not only causing good seal but also good fixation. So here's an example of a graft that goes up into the aorta above the level of the renals, and it is partially deployed. The top cap is kept closed. These are gold band markers here, which show where the renal artery comes about. Here's another gold band marker here that shows where the renal artery comes about on the right side. And these lines show the alignment of the graft here. These are 3 gold markers that are there to show you whether this is anterior or posterior in the graft. Obviously, to do such complicated procedures, you need good imaging technology. And 64-slice CT with software reconstruction is going to be very critical when you undertake this task of doing complicated fenestrated and branched endografts. So once the graft is partially deployed, you then go through the graft, through that fenestration into the renal artery, and cannulate the renal artery on the left, and then, of course, the renal artery on the right side too. And once you've done that, most part of the operation is more or less done. Then you can put in, through those areas, you can put in either your covered stents, like the ICAS stents, which are balloon expandable covered stents, or even just regular balloon expandable metal stents. It depends on where exactly the renal arteries are coming off. If they're coming off the aneurysm, it's better to use covered stents rather than use just metal stents here. So once you've done, then you deploy the entire graft above, and you can see up here, the SMA sometimes comes up right here, and you do not always have to have a fenestration. You can just have a graft that has a scallop over here. So there are different varieties of these grafts that are available right now, and each of these grafts, of course, have to be custom-made for that particular patient. And then, of course, once you've done that portion of the graft, the critical portion, you put a regular endograft here, and like the Cook regular endograft, and then you seal the whole aneurysm, as you can see. We've put the right limb here, and now you put the left limb on the other side, and the aneurysm is now completely sealed with 2 stents, covered stents coming into the renal arteries here on either side, good fixation. You can see the SMA, you can see a branch of the celiac. All the visceral branches are patent, and the aneurysm is completely sealed. And you can see the completion angiogram there with the visceral branches, as well as you can see maintaining patency of the iliac arteries down here. As technology advances, right now we are covering more branches. We're covering the internal iliacs, we're covering the subclavians and thoracic. Eventually, these branches may play a very important role when we start doing thoracoabdominal aneurysms to prevent paraplegia or even neurological deficits. So even nowadays, even in terms of the iliac arteries, people are trying to preserve the internal iliacs. Supposing you have an abdominal aneurysm and then you develop a thoracic aneurysm, then you're covering off a lot of these branches that can potentially cause ischemic neurological complications. So this is an example of a fenestrated endograft, and you can see a close-up picture here of how the stents go into the renal arteries on either side. This is the orientation of the graft. These are the gold markers for the renal arteries. And this patient did really well. This was the one case that was done live. Then technology is again advanced, and you can see now they're putting in branches not only into the renals, but also into the SMA and also into the celiac artery here. And you can see a clear picture here of a complete thoracoabdominal aneurysm that's been treated with a branched or fenestrated endografts. You can see the branches going right into the renal arteries, into the SMA, and also into the celiac artery, which is a fenestration rather than and you can see by 3D reconstruction, very good imaging. And this imaging we get now, even on a 64-slice CT, as Dr. Sutherland will tell you, we get very good imaging. Most of the measurements are done preoperatively, and that is the whole key of the procedure, is to get good preoperative imaging and measurements. So thoracoabdominal aortic aneurysms, open operations are fraught with, it's a big operation, there's no question about it. Patients stay in the hospital close to 3 weeks or so, and the mortality morbidity may be pretty high in these operations. So there are different kinds of thoracoabdominal. Right now we are pretty well versed with dealing with these infrarenal sort of abdominal aneurysms with a longer neck. The current indications for fixing infrarenal abdominal aneurysms, you should have a neck of at least 15 millimeters, infrarenal neck, and the diameter should be between 26 to 28. Then you have what is known as a very short infrarenal aneurysm. And here, in these cases, you can probably use a fenestrated graft and use metal stents here. And then you have these juxtarenal or sometimes even thoracoabdominal that involve the celiac, the SMA, and both renals. And in those cases, you should use covered stents or branched endografts. This is how the graft is basically made. You can see there's got a small hole here, and these sizes can vary. This is a fenestration. They can come in 9 millimeters, 6 millimeters at different sizes. There are 4 gold band markers here that identify exactly where this fenestration is. And the graft can be rotated before you cannulate it into different directions. And once you cannulate it, obviously, you can go ahead and then put your covered stent, inflate the covered stent with a balloon so that it doesn't cause a big ledge over there. And here's an example outside. You can see the graft. A covered stent has been put in here, and then it'll be flared with a larger balloon so that it opposes well to the aortic wall, like here. And this is, of course, they're making custom-made even branch stents too, but this is the commercially available ICAS stent that we normally use for covered stents right now in the renal arteries or even in the coronary sometimes. So that's an example of how you go about making a fenestrated graft. Here's an example of a fenestrated technique for thoracoabdominal aneurysms. And they're different. They're fenestrated, they're branched, and there are hybrid techniques to treat these complex aneurysms. Here's an example of fenestration. Basically, the graft has multiple holes in it. And these are all based on the face of a clock, based on your 3D reconstruction measurements and where exactly the SMA, the celiac, and the renals take off. So you can see now here, this renal is taking off at 3 o'clock, 9 o'clock, this is about 11 o'clock, and this is about 12 o'clock. So you need to know the orientation of the takeoff of these arteries before you can make an endograft for these patients. And then you cannulate each fenestration into the particular artery, into the celiac, and then into the SMA. And then once you're able to cannulate it, most of the work is done, you put in your sheets, and then you put in your stents or your stent grafts or covered stents. So that's an example of fenestrated technique, and this is one of the cases also we did at Adelaide in South Australia. Then there is what's known as a side branch technique. And in this case, you may have to come either from the top, you put in the side branches, because now you don't know the distance because the aneurysms are so large, you don't know how long a graft you have to use. So when the branches come off the aneurysm, you may have to use a side branch and then use that side branch to cannulate into the visceral arteries. And for this, you may have to come from the brachial and then cannulate each side branch into the respective SMA, celiac, and the renal arteries, and then put covered stents in. And therefore, that way you treat the entire thoracoabdominal aneurysms. So that's an example of side branch technique. So you have fenestrated techniques, you have side branch techniques, and finally you have what's known as a hybrid technique, because obviously the most difficult portion of this particular operation is to get into those side branches, cannulate them, and then put stent grafts into the side branches. So anything that can make this easier is obviously better, and this can be very time consuming at times. So the hybrid technique is a little different. In this case, you go from above and below. So you put your endograft in, and this is a new development actually, is if you see these wires that come out from this side, they come along with the device. So they're already cannulated into the side branches, and they just come out the end of the graft over here. So what you do, so basically your two branches here are already cannulated, so you don't have to spend too much time cannulating them. So you get through the renal arteries through these side branches here, which are two fenestrations. You take care of the renals there, and seal the aneurysm right there through the renals. Then you snare the wire from the top of the brachial artery, so that now your cannulated area of the SMA or the celiac is already there. You already cannulated it. You pull the wire back a little bit, put your sheath right at the origin of that branch, and then cannulate into the celiac, and then put your stent graft. And in a similar fashion, cannulate into the SMA, and then finish the operation by doing this. So that's called the hybrid technique. And we've done. And this is the new technique, and they've just started doing this in a lot of these thoracoabdominal operations. Dr. Anderson has done about 70 patients, and he was recently audited in Sydney, in Adelaide actually, and he had one complication, one renal artery closed off after about, I think, 2 months or so, and they couldn't get back into it. And there was one patient who died 3 weeks following the operation. So the results have been fairly good. In the United States, they did start a phase 1 fenestrated trial. There were only about 3 or 4 centers in that one, and now we have the honor of participating in either the phase 2 or a registry trial, and we'll be one of the few centers selected to start doing fenestrated and even branched endografting soon. A little word on, this is another case of the hybrid technique, and you can see this graft here. So you have two holes here, two fenestrations for the renal arteries, one here and one here. This is the device that comes with the branched grafts already cannulated for you with wires in it, and you snare these wires from the top, and then this will go into the celiac, and this will go into the SMA, and then you use the fenestrations to go into the renal arteries. This is another case that was done, and you can see these are previously already cannulated SMA and celiac branches, and you've cannulated the renals through these fenestrations, and you've then basically sealed the entire thoracoabdominal aneurysm. Right now, like I said, we do have the Cook fenestrated trial, and I think we are working on getting approval and FDA clearance to hopefully do a live case during Congress, and I think it should go through. If not, we will still get the trial any which way and start enrolling patients. So that's one of the new trials that we have at present. We also have the Cook thoracic dissection trial, which is a little different from the other endografts in the sense that it has a covered portion to seal the entry tear, and the distal portion is lined with basically nitinol stent material, like Gianturco stents. It's a little different concept, but that's a second trial that's coming up right now. We also have the Cook thoracic TX2 trial, which we've had for a while, but unfortunately we've enrolled only one patient. And that's something I wanted to talk about a little bit, is that we all have to be very aware that even though when we get these protocols and these trials, we have to enroll patients. Just getting the trial in itself may not be a big deal, but enrollment is what the big deal is. And we should endeavor to try to screen as many patients as possible to enroll into these trials right now, so that we can stay ahead of technology and also keep companies offering us the new technology. There is also a TAG 0401 study, which is the high-risk GORE protocol. And there's also a TAG other protocols of abdominal and as well as post-FDA clearance protocols that are coming about right now. But the key message is that we've got to screen, we've got to enroll, and everyone should not basically say it's my patient or your patient, things like that, but just concentrate on enrolling patients as part of the institute, as part of the hospital, and try to get as many patients into these protocols so that we stay ahead of technology itself. And that's the bottom take-home message, actually. And then, of course, there are a lot of hurdles. You may have to go the extra yard. You may have to face a lot of regulatory, financial, economic, and institutional burdens. But eventually, I think we'll soon be up there as part of the Arizona Heart Hospital and endeavor to do upcoming technology. Thank you.
More information about these programs can be found on our website, cvmd.org. Copyright VAS Communications.